Okay, and we've got one more person coming. All right. So welcome everybody. Thank you so much for your interest in this pre and post frenectomy treatment for infants. I know we have some parents, we have some lactation consultants, and even some providers of the frenectomy. So I think it's going to be a very nice discussion. Um, if you have questions, I'd love for you to put in the chat. So please do that if you want me to address things. I have Kathy Matias Riggs here next to me, and we're about to introduce her. I'm going to share screen and start the presentation. Okay. So, PhysioPartners Renaissance CranioFacial Group is the company we work for. We're very much a head and neck TMJ upper quarter physical therapy clinic that also treats infants with tongue tie issues and plagiocephaly and torticollis. So, Kathy, oh, if you want to come over here a little bit. That's okay. That's okay. You know what? I'll just do this.
Hello,
This is Kathy. Kathy is a physical therapist. She has a degree from the University of Michigan. She has a focus on osteopathy in the cranial field, which she's been treating infants to adults with concussions, plagiocephaly, headaches, traumatic brain injuries, TMJ, and spinal dysfunctions of the back and the neck. She's been trained under Dr. Fred Mitchell and Dr. Greenman for functional manual medicine. It's basically what osteopaths do, but as physical therapists, we do the same thing. We're trained in that technique, but it's called functional manual medicine when physical therapists do that, correct? Okay. So she has her certification in this. She's been certified through the University, Michigan State University College of Osteopathic Medicine. She's been working with adults for the past 20 years and with infants for the past 9. I myself is Dr. Jennifer Hobson. I am someone that's known in Chicago for TMJ. I studied under this, and I still study, and I go to Chile every year in January, study under Dr. Roccabato. I also am a Buteyko breathing instructor and a myofunctional therapist. My myofunctional therapy background, I need to admit somebody here, is because my own kids were tongue tied, both my kids and myself. So I come from a background of knowing a lot about the head and neck and wanting to understand why my kids had tonsils that were swollen and adenoids that were swollen. So I became a myofunctional therapist. I am someone trained by the Academy of Oral Myofunctional Therapy, and I also teach through that group. I also am involved in the craniosacral treatment here at PhysioPartners Renaissance CranioFacial Group. I am also getting certified in the Michigan State program. I'm way behind where Kathy is, but I'm much more the oral person when it comes to the infants. And the past 3 years, I've been treating babies for craniosacral dysfunctions. And I know that there's a whole part of the system that doesn't get addressed in normal physical therapy without that craniosacral part. Okay, I keep going. So what's wrong with this picture, everybody? This adorable little baby. And by the way, just disclaimer, American Academy of Pediatrics does not support prone sleeping just because of SIDS, but that's not the point here. The point here is the mouth of this baby. Open, super cute, but not healthy. Not healthy for a baby to be breathing like that and sleeping like that. It leads to this, right? It becomes a child, a toddler that has the same problem. And what's happening in the mouth, you'll notice that the tongue is down. So the tongue, what it does is it grows the face of the child forward. the mid face starts to grow forward if the mouth is closed and the tongue is in the roof of the mouth. That does not happen. So it ends up leading to a very narrow arch. So here's your palate. Here's the width of your palate needs to be the size of your tongue. And what happens when it's not the size of your tongue? It has to go down. So that's what ends up happening, is that the palate, if the tongue doesn't live up there as you grow from a child to an adult, it starts to shrink the size of the palate and the tongue gets stuck kind of low. Now look right above it. What happens to the nose? I can talk from experience. I have a deviated septum that I had no idea about without any injury, but my palate is super high like this because I was tongue tied and I grew up with a low tongue posture. So you end up getting a nose that is bent and hard to breathe through. That doesn't look easy to breathe through. And the harder it is, it makes the mouth want to open even more. Okay. So, this is another article that just shows you that endoglossia, that's the tongue tie, there's a risk of the maxillary, which is your palate, hypoplasia and soft palate elongation because of it. It's just another example of the changes in your craniofacial development of your infant when the tongue is not addressed with this type of treatment, right? We want our tongues to live up on the roof of the mouth with full flexibility, and the lips to have full flexibility, so that your face and your nose and your breathing apparatus grows in the right, the right direction, the right form. You don't want a bulldog face. You want more of a face that grows forward. Okay. So what are the benefits of breastfeeding? Benefits of breastfeeding for the baby: you have less upper respiratory infections, less GI issues. You'll have, and really during the first 2 months of breastfeeding, less GI issues when you use, when the mom and the baby are nursing. There's also a lower risk of SIDS, a lower risk of childhood obesity, a decreased incidence of atopic diseases, which is like allergies, and also increased neurodevelopmental benefits. You'll have the right size of the palate, the right mid-face development, and a lower risk of diabetes mellitus 1 and 2. For the mother, it also decreases postpartum depression, increases weight loss after having the baby, and it decreases the mom's chance of diabetes also. And it also reduces the chance of her getting breast and ovarian cancer, and decreases of the infant neglect. So basically, in essence, it's the right way we're supposed to really develop our mouths. Babies are so weak. They're so, they have no strength. So the fit of the mother and the breast develops the mouth of the baby by natural ways, right? Because it's not a plastic bottle, it's not a rubber nipple, it's just fits right when there's no ties. So breastfeeding recommendations: you have the American College of Obstetricians and Gynecologists. They recommend the first 6 months. The American Academy of Pediatrics recommends 1 year if it's mutually agreeable to both the baby and mom. And also the World Health Organization recommends up to 3 years. So what do you see here? So this is something that I see a lot with our lip-tied babies. So lip tie, we're going to see a couple pictures of that soon. It restricts the lip from being able to flange completely, right? So we want the lip to be able to really, let me see if I can show you, really come really close to the baby's breast, so you don't have too much space between the baby's breast and that lip. When it cannot get close, it's going to be more of a superficial latch. Hang on a second. So this, when you see a curling in of the baby's lip, that baby's not going to be able to really get too close to the mom's breast to have a good latch. Here is an example of how to get the baby on mom's breast in a way that they're getting enough of the breast under the tongue so that the mouth is over the nipple enough to have the tongue compress that breast and a flange of the upper lip to have a nice latch. So what happens when there isn't a nice latch? You'll get nice cuts everywhere, and abrasions and mastitis and, you know, milk ducts that get clogged. It's awful. Mom gets very frustrated and she ends up thinking it's her fault. And as we know, it's not. Many times this tongue tie issue and lip tie issue get overlooked. And thank goodness we have very good frenectomy providers here in Chicago that are even on this call today. Dr. Strumpf is here, and Dr. Welke is here. Let me see if anybody else is here. I don't know if Dr. Strumpf is your colleague also one that does frenectomies?
Yeah, yes, Jennifer. So it's at our practice, it's Chicago Pediatric Dentistry, and it's myself, Justin Welke, Dr. Derek, and Dr. Matt as well. So Dr. Derek and I are in the office this afternoon, and Dr. Matt is attending from home.
Wonderful, wonderful. Okay. So we're lucky to have them, and hopefully we can ask some questions. There's parents on the line also, so hopefully if there's any questions that can come up, please ask them. So what do we do for these babies? Like I hope that we get to see them before they get this procedure done. Why is it so important? Because we want to teach, our team wants to teach the intraoral soft tissue releases before the baby is actually released. If you've ever gone through this, I've gone through this with 2 children. It's just the most stressful 2 weeks of your life as a young, parent, trying to help your child, scared that you're hurting them. They have an incision, so it's going to hurt. So I prefer that they learn this before they have it done, practice it at least a couple days, and then have it done. So you release the tongue and the lips before it actually happens. So I teach them to lengthen the upper lip, the soft tissue of the upper lip, the frenulum up the upper lip. That we also teach them to lift the tongue to the palate to stretch the lingual frenulum. We teach them how to release the posterior tongue, how to release the floor of the mouth, how to do gentle sweeping of the hyoid region, which is the anterior throat where the swallowing occurs, and to do these techniques at least 5 to 6 times per day, pre and post frenectomy for those 2 weeks. Okay. Those 2 weeks post frenectomy is when things really seal up and heal up. So after 2 weeks, it's hard because the reattachment happens within those 2 weeks. And if you don't do these exercises, the chances are the baby might reattach and you will have issues with nursing and even more scarring, which makes the tongue tighter. So I'm going to show you a quick video. I blurred out the eyes of this baby, and this is not a baby. It's not an infant, but let me see if I can share with you. Intraoral. Ready for me? Okay, so we're going to go here. Bring your fingers on either Can you see this? Of her lips laterally. Yep. Okay. And you release right there. You're going to start holding the lip and pulling down gently. So you really want that upper lip to be flexible in many directions, not just every up. Single little nook and cranny of that upper lip you want to try to stretch, and then you're going to cover the nose. So this baby needs a frenectomy. Dad has not wanted to do the frenectomy, but we're working on just making everything flexible. Just like that. So you're pulling down and then you're covering the nose. You want to cover the nostrils when you do this. You're going to go right. So that's called a 90-degree sweep. I will
Right at the scar. That's going to be a labial frenum scar. And that's called a 90-degree stretch. So you're going to go right on the gum and up at the gum line and over. Then,
so that upper lip right at that scar right here, you'll see a little diamond. That diamond is very normal to look nice and like white eventually. A lot of parents get nervous that it starts to look different. You want to sweep through it so that when the baby is mouth closed, that it doesn't adhere itself. So I'm very particular about making sure that they go through that scar.
Are normally a little bit more at the back, on the vestibule of the cheek. You want to just kind of stretch out.
So some babies don't
Now
open wide enough, so we'll do a lot of
my
just
fingers
stretching of the mouth
the
in
tongue.
general.
She wants the bite.
Here we're going under the tongue on either side of the frenulum.
On either side of the frenulum. So, Kathy, see if you can see. Oh, there's our teeth. So I'm on either side. My third fingers are touching in the chin. I'm going to open and stretch that thing. There it is. Stretch it out.
So my third finger is pushing down at the mandible to open.
And pull up gently up towards the palate. All right.
So do you notice that lengthening? You want to see that traction. You want to see the whole length of that frenulum to get a good stretch.
There, so you want to stretch that little cord. Do you see the cord, Kathy? Then you can do that same 90-degree sweep right against that. There's going to be a scar there. Right now I feel like a guitar string. So I'm just kind of sweeping through. Now, with my right hand, I'm going to go under her left side, get under the tongue. And I'm going to work all the way back, as far back.
So a lot of people don't go back to the back of the tongue. And the back of the tongue, if it's been adhered all through, pregnancy, the back of the tongue gets very tight.
Back as I can go, and I'm going to sweep medially. So I'm under the left side.
So I'm just under the tongue at this point.
And then I'm going to go all the way back, Miss Tadia, all the way back, and I'm going to stretch the back part of her tongue, and then I'm going to work around that. She's really tight back there. And I'm going to go again under the tongue. Wait, stretch the base, the bottom of the tongue all the way in the back. With my finger there, it just stretches it up, and I'm going to wrap around. Same thing on this side. Index finger to the right of the frenulum. I'm sweeping medially. None of that muscle. Part of that muscle gets a lot of movement because she's really tight. Then you want to, after you sweep medially, you go all the way back. Stay there. That kind of is uncomfortable because you're stretching back there. And you wrap around the tongue. Under. Wait. They might gag a little bit. Wrap around the tongue. Again. So 2 fingers under the tongue. Stretch that frenulum. Stretch that frenulum. And take a break.
Okay, so that baby did amazing, considering if you all have ever gone through this, what it's like to do it. Babies cry. That baby, I asked the dad, I'm like, can we film this? Because she was just such a good baby. I'm going to go back to the presentation. Okay, so now what I'd like to do is kind of go into osteopathy, and I have Kathy here, and I videoed her with an infant that the mom agreed to do this, that explains what she does, because she's the expert. She's amazing at this and has helped so many babies. Let me just go back. Uh-oh, hang on a second. Let me go here. One moment. I need to go here. Okay, so I'm going to stop screen, share this one, and play. We have a model of an infant skull. Can you hear this, by the way? Can you hear the video okay? Yeah? Loud enough? Yeah? Okay. The white aspect of it, this is all bone, and the blue is membranous. It's membrane. So the soft spot we hear about on babies' heads that we can sometimes see the pulse is this part right here. So the bones have not met. They do not fuse, but they do eventually meet like pieces of a puzzle that come together, and they should be able to move and slide a little bit, even into adulthood. And you don't want any aspect of the sutures in the adult skull to stick and get stuck. So if we open up, this one does not open up, but this one does. And we take a look inside the skull. This is the vault of the head. This is the base of the head. The pink bone is your sphenoid. And the brown bone is your occiput. Together, they come together to form the spheno-basilar symphysis. And it's pretty much in the center of the head. It sits underneath the brain. On top of it is the pituitary gland. And when osteopaths who do cranial work assess the head, this is one of the first joints we look at to make sure that it moves properly, that it flexes and extends or twists in the normal range of motion. If it does not, if there's a twist, inordinate twist, and possibly a twist, and then the joint stays that way, it can result in asymmetry of the periphery of the head. This can lead to some visual problems, hearing problems, malocclusion with biting, feeding issues like reflux, or difficulty latching onto a nipple, all of which can affect the thriving of a baby. Your orange bones here are your temporal bones, which house the eardrum, the ear canal. Your blue here is the frontal bone. And then the green bones here are your parietal bones. Put that back on, you can see it's the top of the head. So with osteopathic craniosacral manipulation, we not only look at how well these joints move together, because you don't want any part of it to stick and not move. And also within the cranium, there's a dural system. It's like a lining of the head. So we evaluate how well does this lining move in addition to the joints of the skull. Think of a lining in a skirt. If you pull too hard on the lining in a skirt or in a pair of pants, it will move the fabric on top. And you don't want asymmetrical or inordinate amount of pulling on that dura inside the skull. Okay. What happens when the baby goes through the canal? What may happen to the cranial bones, the sphenoid? So if the baby is passing through the pelvic, the canal, the birth canal, and there can be, again, some misshaping of the head if there are appliances in there to help the baby come out, or hands, or perhaps the pelvic bone, the pelvic opening is just too small for the size of the baby, you can get a certain amount of pressure and squishing of the head as it comes through. Now, a certain degree of that is normal, and you want that compression, which kind of jump starts the nervous system, because if the head is realizing I'm being born, and then as it comes out of the hole, you get a release and kind of like a jump start of the CRI,
or the primary respiratory mechanism. So if there's a misshapenness of the head, is that after it comes through, it can lead to all the feeding issues and visual and hearing problems later if not addressed. Does that answer your question?
All right. So, so we want all our babies to be.
Hello and welcome. My name's Michelle. I'm going to take you through some basic first aid videos on behalf of Get Licensed. So
sorry about that. Let me turn that off. Okay. So I'm going to show just a quick video on what this looks like now. Okay. So this is going to be Kathy's video with the baby. Okay. And hold on. Oh my goodness, not here anymore. 1 second. Kathy, could you tell us how often you see babies? Just come here for a second. I gotta find this video. It's no longer here. So could you explain to everybody how long you see babies?
Well, if Dr. Hodson has asked me to co-treat with her with a baby that is planning on having a frenectomy, she likes me to see the baby ahead of time to kind of get a baseline of how well this baby's head moves. Are the cranial bones in the right position, and do they all work together? Now, oftentimes the occiput is really in 4 pieces when a baby is born, and as they pass through the canal, or sometimes if they've been during the last 6 weeks of gestation, the baby has been cramped, or their baby A or B of twins. Sometimes you get a distortion of the condyles that make up the occiput, so that when you go to really look at and assess how symmetrical is this cranial base, you want symmetry, because the temporal bone and the occiput form the hole that forms the jugular foramen. And we know that cranial nerves 9, 10, and 11 come out of this, which
7 out of 10 deaths in the U.S.
which control your soft palate and your tongue. So if you get impingement of these cranial nerves, you can get difficulty with latching and with control of the tongue to prevent leakage of air or milk coming out of the mouth. So how often do I see babies? Well, pre-frenectomy, yes. Post-frenectomy, yes. And depending on what else is found, sometimes I've had babies where I just treat once, and they're the release of the frenectomy releases the dural tension in the head enough that the symmetry is there afterward. Sometimes it takes longer. I'll see the baby once a week for several weeks, and then taper off as the baby's head becomes more symmetrical and the baby starts gaining weight and is thriving better, latching on better, less gassy, gas and reflux issues. So at that point where we feel like the baby has a symmetrical head and is feeding well, we usually recommend that the baby come back every 6 months until they're 2 years old. And that's when the head becomes significantly hard and more difficult to take cranial treatment.
Awesome. Awesome. Thank you for that. All right. This is just an example of her treatment. Let me just get through this phase of, there, we're going to skip that ad. Okay.
she's left and right now, and her neck is getting really strong.
So this is a baby that had a frenectomy.
Left and right.
and is at the final stages of, we're about to discharge her soon, I think. This was, you know, a colicky baby. And this is on YouTube. A lot of people have watched this because they've wanted to see what Kathy does. This is a great example of just to show what we do to babies that are colicky.
Get my hands underneath her head. So initially, I'm going to feel for just the hardness of the head, relative hardness and softness of the head. She's looking for her thumb. She's obsessed, really.
You know what? I'm supposed to start at
Good
30.
cranial endurance, INDURANCE, not endurance,
Okay.
which is a relative softness of the head. Softer is better.
Okay.
And it's okay. It doesn't feel like it's too hard. It feels like all four quadrants, front and back, are moving evenly. Expansion and contraction. And I'm just going to look at the back of her head from this position. Tiny bit of flatness on the left occiput, but minor. It doesn't sound like it's affecting her function right now. Anymore, I should say.
And would you say that's because she used to prefer turning to her left before?
Right, because she would roll this way and then side bend.
Yeah. So now
Roll to the left, side bend right, but now just watching her spontaneously move, she goes this way. I'm going to check how well her head moves. Flexion and extension. It's cranial flexion, cranial extension.
You ever wondered what actors and actresses?
Sorry. I'll stop share here. Okay, let me go back here. We're almost done. And listen, I know if you have to go, we're a little over, but just know that I'll send this to you if you don't see the whole presentation. There's videos that I can also include in the email that you can see these whenever you want, but there's different types of holds that we do. What Kathy's really trying to do is pick up on the symmetry of the skull and the moving, all the bones of the skull, that they're moving correctly compared to the right and left. And also that SBS, that sphenobasilar symphysis, if it's compressed. There's this one more video I'd like to show you. Hang on a second. What did it say? 222. Okay.
On Lila. I'm going to take her head into cranial flexion, cranial extension. I'm trying to see if I can pick up on any parts of the skull that don't move as well as the others. I'm looking for symmetry. so good. Maybe a little bit on the upper, in the front left. There might be a little bit of a restriction here in this area. Might be.
And that was her original area, right? That had some.
The spinobasilar symphysis in the middle of the head was compressed.
Okay.
And that was, I think, part of why she was not able to relax so well before. But that's fine now.
Okay.
That joint is fine. So the joint I'm referring to, or joints, are more on the periphery.
Okay.
Like near the temple on the outside here. So I'm going to work on getting those joints to move a little bit better. So rather than this joint that was compressed before, it's moving well now. And then here, I'm looking at these joints.
Oh, okay.
Here.
Where all those meet.
Mm-hmm.
Okay.
Where all those meet, where four bones meet, that's called pterion in Latin. Pterion meaning four. Pterodactyl.
Gotcha.
So
She's going to start.
lift your head a little bit. This is a fronto-occipital hold.
It's a little fussy here, so I'm going to fast forward it.
She's sleeping well.
Oh, she sleeps great. Like a lot through the night.
Good.
She's sleeping from 8 until.
Okay, 4:14. We're just going to fast forward a little bit.
Shape the back left of her head.
So if you can see how gentle it is, a lot of parents get nervous that this is, what is she doing, or why are we doing this? And it's a very gentle treatment that kind of guides the nervous system and it guides the cranial bones. It is one of the healthiest things to do for infants and really anybody, but it's because it's so gentle, infants do really well with it. Okay, so I'm going to stop share here. And okay, so one last thing I wanted to show you is what the parents. Kathy, do you mind telling everybody, sometimes we have to explain to parents why this is important for their infant, because they're new. A lot of them are new parents. They don't know anything about being a parent, and they're nervous that something's going to go wrong or that you're doing something that might hurt their baby. How do you explain to them what you do? I gotta find this other thing. And I'm gonna stop share so you can see her. So explain to everybody what you explain to patients, parents, about why this is important.
Okay. So oftentimes when parents come in with their child, they come in knowing that they've seen the flat spot on their head. Either they were born with it or it developed maybe in the first or second month, and the doctor has noticed it too, and then they refer them to me. And usually the parents their biggest concern is that they want the head to be symmetrical and look nice. They often say, I don't want my child to grow up with a misshapen head, and I don't want them to be made fun of, which of course we want a nice looking child, a nice looking head. But more than that, functionally, if you have a head that works well, the cranial bones are in position, they're moving well, you get a head that expands and contracts. That's called the CRI, the cranial rhythmic impulse. It happens between 10 and 14 times a minute. And the only people who don't have that are dead people. But every mammal's head expands and contracts. So functionally, you want everything in the right spot so that your head, the hard drive, is in place. And by having all of the bones in place, you are able to position your tongue in the proper manner and the proper position, and you get a spine and a body that forms how nature wanted it, and neuroreflexively strong. So we need to take care of the head, which is the hard drive, get it symmetrical so that
Could you describe your baby's temperament before?
So that this child has a symmetrical palate, symmetrical jaw, so that they're chewing properly, and also and it has proper ability to articulate and to swallow. So, it's not just about aesthetics. You need it for proper growth and how nature intended. And oftentimes too, I will explain to parents, I'll put my hands on their forearms and just apply the most amount of pressure I ever use on a cranial head so that the parents know, oh, okay, it's really not that much.
Awesome. All right, this is the last video. This is of the mom after the patient. It was, I think, the day that we discharged the infant. This was a colicky infant that she had no idea he was tongue-tied. We identified it, treated the tongue tie. I think she saw Dr. Milton Gavelis, and we treated her post-frenectomy as well. Before and after these 3 sessions with Kathy?
Before her temperament, she was very concerned all the time, always had a furrowed brow. She was very stressed out and crying all the time, and we couldn't console her.
So what was her temperament after the 3 sessions with Kathy?
After each session, we could tell that she was gradually becoming more calm. She was also able to nurse a little bit better each time. And she was able to move her head better back and forth. Before, she was only able to move, she preferred only to move her head to the left. And afterwards, she was moving to the left and the right.
So could you tell us what the end result of both the post-frenectomy care that you had here and also the cranio-osteopathic, craniosacral treatment? What was the final result of Lila?
Final result is that she is nursing perfectly. We look forward to each nursing session now, and we're bonding. I'm able to bond with her instead of me being frustrated and her being frustrated. We can enjoy each other all the time, not just the times we're not nursing, and that she is a lot more calm. We can take her out in public and she's not freaking out all the time. She stays calm. We can console her, whereas before we couldn't get her to calm down. So it's a lot more enjoyable all around.
Would you say your child had colic symptoms? Would you call her having colicky?
I think so. Yeah, we were questioning if she did, because we couldn't get her to calm down even at night. So now she's a lot easier.
And would you recommend this type of care for any colic child or any child that had issues with nursing?
Oh, definitely. Definitely. I think it's made her more focused. And then also with the frenectomy and following up with those exercises, it has gotten her to nurse a lot better and a lot more effectively. She can do what she needs to do now without any other distraction.
Wonderful. Thank you so much for coming.
You're welcome.
All right. Awesome. I think that is it. We just talked about, we actually talked about this. Kathy had recommended that as the baby grows and bumps her head, we recommend that they have a continuous checkup every 6 months until they're about 3 years old, when the head gets harder. It's 2 years old? Yeah. 2 years old. Sorry. At about 3, the head's too, basically a harder head, right? So, and we just want to make sure that the head moves symmetrically, that the spine and the pelvis move symmetrically in flexion and extension, that it's able to move right and left and forward and backwards symmetrically. You want that the head develops symmetrically side to side, front and back, so that there's no bite issues, no malocclusion, no swallowing issues, or breathing issues. That this cranial rhythmic impulse is about 12 to 14 beats per minute, 10 to 14 beats per minute. And basically, we want all our children to grow up tall and healthy. And I hope you enjoyed this webinar. And if there's any questions, I'd love to hear some questions. I'm going to go into, let's see here. This is Liz. For infants that have posterior tongue tie, that have a significant stridor during feeds, can you explain what causes the stridor aside from laryngomalacia as a comorbidity? Laryngomalacia. Is there a way to distinguish between the cause of being posterior tongue-tied or laryngomalacia, other than time, age of infant, or release itself? Liz, can you go off of mute? Do you
Sure.
mind? And then craniosacral therapy and head molding, do you feel that that is a factor that contributes to anterior bubble palate and recessed chin? Meaning that the CST treatment itself will help those things, and how long the treatment to see movement, assuming posterior tongue tie is released.
I don't know about the first
question. I don't know about the first either.
So laryngomalacia, they tell us, I'm a nurse as well as a lactation consultant, and laryngomalacia is that flappy laryngeal, like flap, that a lot of times will cause the stridor. They tell us, the neonatologist will tell us that. And so I auscultate a lot at the infant's neck to listen when I do feeding to see what the transfer is like. Because a lot of times the babies are really tricky, especially with any like tethered oral tissue. There's very small boluses happening, and usually their suck-swallow ratio is really dysfunctional. And so it helps me kind of really understand what the problem is in moving forward, if it's mom's milk supply or the baby, and the movement of the tongue. So I have been finding, actually Maureen is on the call as well. I work with Maureen pretty closely because a lot of the babies that have significant stridor, the doctors will jump right into, oh, it's laryngomalacia, and not really associate it with the tongue tie. So I was trying to differentiate if it's like, which comes first? Is laryngomalacia always the factor when you hear stridor, or if it's from the tongue itself not being able to?
I don't know if we can really say for sure.
Yeah.
Sorry. That's a tricky question.
Okay.
So how about the second one? This is more about.
Yeah, the craniosacral therapy. I was just wondering, with these like anterior bubble palates that are really high arched, and I know that they're more narrow because of that tongue not molding the palate properly. But I was just wondering, like, is consistency obviously probably the answer for CST? And a lot of these parents, unfortunately, can't pay for all the different modalities. So I think we don't see a change like we want to as fast as we'd like to. But I was just kind of wondering if that anterior bubble palate just will on its own start to recess and become flat, or if the craniosacral therapy is always the answer.
So you're saying at this age,
like an infant age, yeah.
Age. So how do you notice that the craniosacral treatment reduces the height of the palate?
Correct.
And,
yes.
And how long it takes to see a change is what she's wondering.
Mm-hmm.
We only see them for
a short time.
It's a short time.
So we probably see babies maybe for 4 to 8 sessions. Okay. And within the time, how do you feel about the palate change?
So if the tongue tie is released, either anterior or posterior, and the child is able to get the tongue up on the palate, then what happens biomechanically is that the pressure of the tongue moves the midline bones of the cranium like cogwheels, such that you get end flexion of the sphenoid and it expands the head. And every time you get your tongue up there, you're expanding this head. And especially if we get our tongue up there like 1,500 times a day when we swallow, 1,500 times a day at least, we're getting a head that's expanding, which the head loves. So when the tongue is up there, you're going to get flexion of or external rotation of the maxilla, so that your palate ends up being shallow and wide.
Okay, great.
And Dr. Justin, I think, wrote, it's caused by baby's inability to elevate the tongue due to the posterior tongue tie.
Yes.
So, yeah. And then it says posterior tongue tie will cause stridor due to lack of proper pressure transfer, through causing air and liquid to be displaced, leading to the laryngomalacia. It's a bit of a chicken or egg situation.
Okay.
9 times out of 10, the tethered oral tissue is causing these other issues.
100%. Okay, that's kind of what I was thinking. And oftentimes, I actually think these babies are aspirating up into their nasal passage if the mom has a strong letdown, and that's why they're hearing so much congestion. And they're like, the baby just seems all congested. And a lot of times, they have that head molding that needs to come forward. Plus, I think they're aspirating a little bit into their upper airway.
Yeah. Yep. I would agree with that as well. And Dr. Justin,
thank you.
Exactly. They are aspirating because of improper tongue function. You got it.
Okay. Thank you.
Awesome. Any other questions? These are great questions, though. Okay. So, you know, we have an office in the Loop. We have an office in Lakeview. We're opening an office in Glenview, hopefully in September. This is an area that definitely needs more practitioners treating infants. Infants need the hands-on, and they need people that know craniosacral, but also know the tongue. I've noticed that not everybody is versed in both, but you know, I'm very much, when it's a baby, to me, they take precedence, because babies they're quick to grow, first of all, and they're quick to adapt to changes, and they don't need that much. They just need to be nudged in the right direction. And it's our hope to help babies grow with wide palates that fit the tongue, so that they don't end up having issues with snoring and sleep apnea, like I just see all our older patients having issues with. So if we could really know when to refer these types of patients, we really do like to see them before the frenectomy, just because it's a lot easier to teach parents when the baby's not gone. They've trained the technique before they go and they do the technique. Or the procedure with the provider. But our goal is to help as many babies. So if there's a baby that just looks like they have failure to thrive, that they're not opening big enough, that they are nursing inefficiently, taking too long to nurse, and or getting too tired, those are types of symptoms that or GERD and reflux and things like that. Babies shouldn't have those things. And normally, if you have to have a provider that can analyze the tongue, the function of the tongue, we do a lot of second opinions, just so that, you know, if you're borderline trying to figure out, is the baby tied or not? Do they have a posterior tie, or do they have an anterior tie? We do a lot of just second opinions to help parents. And we have a lot of great providers that do a great job. So we hope you really enjoyed the presentation, and thank you for your attention, and we hope to work together.
Jennifer, I just wanted to add something real quick. Just wanted to say thanks so much for this. This was a great talk. Glad I saw some familiar faces here on this video. So thanks for putting this together. Some really great information. And just to echo what you said, yeah, we are probably the largest provider of frenectomies here in the city of Chicago, between myself, Dr. Derek, and Dr. Matt. And the little bit of information I just wanted to give everyone is the sooner that we see the babies, the better, because the younger they are, the more accurate we're able to be with the procedure. Technology, like so many other fields, technology has really improved what we're able to do. We have a CO2 laser that allows us to be super precise. But obviously, the older the child is, the more they move, and precision becomes more difficult. So the earlier we can see them, the better. But absolutely, we agree with Jennifer 100% that the more paraprofessional support the baby can get from physical therapy, from the IBCLCs, from everyone that can weigh in on this, from OT, the better off the child is going to be. So, if we can all work collaboratively to help out these babies, again, the sooner the better, because it's really tough once a child is 6 months old and they have a super vaulted palate and they've lost, the innate desire to suck and get a latch. And, it's like someone running around with their shoes tied for 6 months and then you untie them and tell them to run. It's a lot harder if they've been running around with their shoes tied together for 6 months as opposed to, say, a week or two. So the earlier the better. But we just wanted to say thank you so much for getting everybody together today. Really appreciate it.
Yeah, thank you for everything. And then just to reiterate, Dr. Justin, we're always taking in patients, and we're always happy to see a consultation, even if it doesn't go through that day, and just explain everything and talk, as the whole picture of everything, as multifactorial as breastfeeding can be. We're here to help. So thank you so much for a great lecture.
And our consultations are free. So, I mean, even if you haven't even never looked in the mouth, but the child's having a hard time breastfeeding, and you have no idea if there's a tie, we're happy to look at it and say, there's no tie. Go see Jennifer, go see a lactation consultant, but there's nothing that we have here to release, and it's no charge to the patient. So no harm in taking a look.
Wonderful. Great. Well, I'll get this on a Zoom link and I'll share it with everybody. Okay. So thank you again for your attention, and have a great rest of your day. Take care. Bye-bye.